of the meeting materials and the agenda for the day. But before I do that, Eileen, I wondered if I could hand it over to you to give the statement from the revisor's office.
Yes, thank you very much, Carly. This is the meeting of the Special Committee on Mental Health Modernization and Reform Working Group on Policy and Treatment. And due to health and safety concerns, members of the public are not in attendance at this meeting of the Working Group on Policy and Treatment, but full access to this meeting is being conducted by medium of interactive communication, allowing members of the public without cost to listen to the meeting through the use of live stream audio broadcasting on the internet and teleconference is available. The link to view this meeting is https://www.youtube.com/user/KS, capital H, lowercase EALTH, capital I, lowercase NSTITUTE/. The agenda and all documents for this meeting have been provided by the Kansas Health Institute. Additionally, a link to the documents has been provided in the comments section of the YouTube feed previously referenced. Each member of the working group and staff will state their name and title every time the individual begins speaking or voting so that the individual can be readily identified by remote listeners. All participants are required to ensure that microphones, telephones, or other electronic devices are muted when the participants are not speaking so that the ability of remote listeners or observers to hear the proceedings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the committee will not recess to a closed or executive session or pursuant to KSA 75-4319 and amendments thereto. Finally, each motion, if any, will be clearly stated before the working group votes, and the chairperson will announce the results of the final vote. And that's all I have, Carly.
Great, thank you. This is Carly Houchin of KHI. I'm facilitating the meeting for today. So quickly would like to provide an overview of the agenda, a reminder on our meeting commitments, and a brief orientation to the materials that you should have received from me in advance of the meeting. So first of all, the focus of our meeting today is on the topic of prevention and education. So as the group is working towards the development of a strategic plan for the modernization and reform of the behavioral health system in our state, the special committee has broken that work out into topics, and we're going to take one topic per meeting. So
welcome to Zoom. Enter your meeting ID by pound.
A moment, getting some background noise here. Let me mute those who are not speaking. Great. Okay. So we are working to develop a strategic plan for the modernization and reform of the behavioral health system in the state. And our topic today, as it relates to that work, is around prevention and education. So you should have received a number of materials from me in advance. As Eileen stated, those are also available and the link provided in the live stream, but also on the khi.org website. The most important document that we'll be referring to continuously today is the one titled WG2 Crosswalk Agency. So working group members that are on the Zoom call here, that will probably be the most helpful document to have in front of you to cross-reference. Specifically in that document, looking at the, I think it's the first page there where it says prevention and education at the top of the table. That is the list of recommendations that we're going to spend the bulk of our meeting time discussing. Those are the recommendations that were kind of assigned to this group by the special committee. And then what we've done is we've copied over the testimony that the state agencies provided to the special committee as it relates to each recommendation. So hopefully that is a document that can give you a lot of information about some of the existing recommendations all in one place. Some of the other materials that you received from me ahead of this meeting include some of the full testimony documents from the state agencies at the August special committee meeting. So those were included just for reference in case more detail beyond what's included in the crosswalk is helpful. as well as we sent around the mental health task force report, as there were detailed implementation plans related to each recommendation included there. That again may be helpful reference, but there's no need to have all of that open throughout. Again, I would just encourage you to have the WG2 crosswalk agency document available throughout our discussion. Okay, so as I noted, a quick overview of the agenda. We're going to spend the bulk of our time with those recommendations that have been developed so far. We're going to go recommendation by recommendation and score them using the rubric that we briefly overviewed last time that was developed in consultation with the special committee. After we spend about the first hour or so of our meeting scoring those existing recommendations and updating them as appropriate, then we are going to circle back to some of the barriers that this group identified on their last call as they relate to prevention and education. I have a list of those barriers. I'll show them to you all. And basically the operating question will be, okay, have we addressed these, or do we need to still make additional recommendations that as it relates to addressing these barriers for the purposes of modernization and reform. Then lastly, we'll have some administrative updates and we will adjourn by 4:30. Before we launch into introductions, want to quickly remind the group of some of the meeting commitments that we've made. Those are on our agenda and we discussed them last time. Just quickly, the commitments include that we're coming ready to both discuss and compromise. This is a consensus-based process. We're committing to keeping our remarks succinct and on topic, doing our best not to reiterate. We're going to speak up when we have questions so that we can get on the same page as quickly as possible. And we will work to start and end on time. With that, I would like to ask working group members, I'll call on you briefly, but just want to quickly run through so that everyone knows who's on the line. Feel free to just give your name in the introduction. And so the first person I'm seeing for a quick introduction is Andy.
Hi, I'm Andy Brown, and I'm the Commissioner for Behavioral Health Services at KDADS.
Great, thank you. Erin?
I'm Erin George. I'm the person with lived experience.
Thank you. Gary?
Gary Hinault, Director of Children's Services, Director of Youth Services at KDADS and one of the co-chairs for this committee.
Thank you. Candace?
Candace and I with Cigna.
Great. Kelly?
Kelly Hance-Reid, Director of Medicaid and Children's Mental Health for DCF.
Great. Kelsey?
Hey, Kelsey Torres, Behavioral Health Consultant at KDAG.
Lisa?
Hi, I'm Lisa Southern with Compass Behavioral Health, Executive Director. Going to be honest with you, I've been diagnosed with COVID and stuck at home on quarantine, and I'm joining the meeting without materials just because I don't want to miss anything. So I'm going to try my best.
Great. Well, Lisa, we hope you get to feeling better very soon. And we are happy to have you in any capacity that you are able today. So thank you for joining.
Thanks.
Next, I see Rachel.
Hi, Rachel Marsh with the Children's Alliance of Kansas.
Rennie.
Hi, Rennie McKinney, Advent Health, Shawnee Mission Health System.
Sunny.
Hi, I'm Sunny Mickle, the Vice President of Government and Community Relations for Blue Cross and Blue Shield of Kansas.
Great. And Wes? Looks like you're muted there, Wes.
No, I think I got it. My name is Wes Cole, and I chair the Governor's Behavioral Health Services Planning Council.
Great, thank you. I think that is all the working group members that we have on the line. We do have a couple of supplemental experts that I'll ask to introduce themselves in just a minute, but want to make sure I didn't miss any working group members.
Deb Stidham, Kansas Association of Addiction Professionals.
Great, thank you, Deb. Apologies there. Okay. So we have, if you'll remember at our last meeting, we, related to each topic, identified some additional expertise that we wanted in the room as we dove into topic-specific discussion. So related to prevention and education, we're joined by two supplemental experts, Shanna Burgess and Debbie Wilsey. Without too much further ado, I'd like to ask Debbie, would you kick us off with an introduction, maybe sharing a little bit about your background and some of the experiences that you bring to the discussion today?
Sure. Thank you for inviting me. I appreciate being here. I don't know that I feel like an expert, so don't expect a whole lot out of me, please. I'm the Director of Field Practicum at the WSU School of Social Work, and I've been here for 7 years. We place students, master's and bachelor's level students in the community. We have about 168 students total placed in our community right now. Prior to that, I worked at first SRS, then later DCF for almost 30 years. So while I was there, I supervised units of child protective services, family preservation. We did juvenile offender work in the old days. I moved up through the agency. I was the Director of Human Resources for about 10 years. Over community relations before I left. So that's primarily where my career has led me. And before that, I worked for in Hutchinson at the Mental Health Center that's now Horizons for about 2.5 years after graduate school. I currently sit on the board of directors for Substance Abuse Center of Kansas here in Wichita. And I also am the vice chair of the Sedgwick County Advisory Council on Aging and Disability Services. So I have a little bit of knowledge in those areas, but probably my main interest is I really enjoy workplace issues. I think because my HR kind of interest and background in working with hiring and retaining staff at DCF when I was there, I like preparing students for the real world of social work and making sure that they're ready both intellectually but in a really practical sense for contributing out in the workplace and helping clients in that way.
Great, thank you. And Shanna?
Yeah, hi, I'm Shanna Burgess, the Director of Prevention and Community Relations at Johnson County Mental Health Center. I started my prevention work here in Kansas at the Regional Prevention Center for Wyandotte County on a drug-free communities grant, and then shifted over to Johnson County, again, working on the Johnson County Drug-Free Communities Grant, and then continued my work as a prevention coordinator here and worked my way up to the supervisor position. And then we were lucky enough to kind of bridge that substance use prevention work with the suicide prevention and mental health promotion being embedded within the mental health center, and now see just the benefit of that community mobilization and community coalition work across all the different behavioral health aspects. So thanks for having me. I've been doing this for, well, probably about 15 years or so, and was on the Kansas certification board when we had certification for prevention here in Kansas, and just do a lot of work with local and regional community coalitions. So thanks for having me.
Great, and thank you both for joining the group today. We've extended the invitation to them with the hope that they will weigh in throughout. I'll just to reiterate, Debbie and Shanna, as we move recommendation by recommendation here, please feel free to share your thoughts and your expertise with the group as you are interested to do so. With that, I will take us to the next item on our agenda. And this is where it will be helpful for you all to have that WG2 crosswalk agency document open in front of you. That is not the document that you see on your screen. So it will look different than this document. What you're looking at here is our recommendation rubric. And what we're going to do at this point is go recommendation by recommendation, spend some time discussing each, and ultimately score each of them for ease of implementation as well as potential for high impact. We're not going to be able to kind of solve every problem as it relates to prevention and education today. This is very much our first pass, wanting to make sure we have the notes that we'll need in scoring in place so that in our last meetings, we can kind of pick and pull different pieces together to come up with a roster of recommendations that will be appropriate to put forward to the special committee as it relates to prevention and education. So I put a call out to the group to look at the WG2 document in advance and let me know if any of those did not need to be addressed. I didn't have any that got crossed off the list, so we're just going to dive in. But I will go ahead and kind of with each recommendation, I'll start us with the same question. So hopefully you can see on my screen here, recommendation tier 2, safety net, early childhood and early intervention. The first question that I'd like to hear a little bit of feedback from all of you as you are reading it is whether this recommendation is part of what it would take to modernize the behavioral health system in Kansas. So first, is this recommendation part of what it means to modernize? Give you a minute to read that. If this recommendation is important for modernization, we can change it as we need to. But if it is important to modernization, kind of having these safety net features, these early childhood programs, and the importance of early intervention as articulated here, would like to encourage us to dive into some of the discussion items under ease of implementation. So as we're thinking about what it would take to implement a recommendation like we're seeing here around fully funding, strengthening and expanding the safety net, as well as early childhood programs through the variety of public services listed there, as well as community partner-based programs. What would it take to implement a recommendation like that? Would it take program overhaul, new programs? How would you rate that in those first check boxes we're looking at?
Carly, I have a couple of thoughts about this particular recommendation. I mean, as written, Deb Stidham, I always forget to say my name. I don't think I'd be surprised if anyone would argue the importance of this. I think for me, it's a little broader than modernizing the mental health system. I think modernizing the mental health system is part of this recommendation, but I read this, especially when I consider probably what all went into the Child Welfare System Task Force. Clearly you're dealing with items such as poverty and housing and all of those things, not that those don't touch our population, they do. But I guess I struggle a little bit with this recommendation for this work. Mm-hmm. If we found a way to drill down in exactly what could be meant by this to modernize the mental health system and what specific recommendation we're talking about for that component, I guess I could get a little bit more excited about it. So to me, it's a little bit of apple and orange right off the bat.
Okay.
That's just my thoughts.
That's helpful to hear. Go ahead, Andy.
This is Andy Brown, and I would echo what Deb said. I feel like this already calls out specific recommendations within the Mental Health Task Force report. So I don't feel like it's necessary for us to include it in what we're working on now.
Great. So I've heard the thought twice, so I'm going to move us forward unless there's an objection. It sounds like we don't need to spend time discussing this recommendation. It's not one that this group would consider high priority, given the we think it's a bit too broad for the what this group has been tasked. Sound okay?
Yes.
Okay. So that will take us then to recommendation 3.4 related to early intervention. And this is from, I believe, the Mental Health Task Force and reads increase access to early childhood mental health services by including language in the state Medicaid behavioral health plans to explicitly cover early childhood mental health screening, assessment, and treatment. So first question, is some form of this recommendation part of what it would take to modernize the behavioral health system in Kansas?
Maybe I'm not quite understanding this, but I feel like this is already covered. In like, this is already something that people have access to. They can get early childhood mental health screening, assessment, and treatment.
Well, they can, but there are some specific like diagnosis codes and things that right now are not necessarily in the CanCare system. And I don't know if there's anybody on the call that wants to talk to that specifically, but I do think that this is a valid recommendation for consideration. I don't know where it would fall on the priority list yet, but I do think it's valid.
Yeah, this is Lisa with Compass. I can't speak directly to what the screening assessments would be, but it is true that there are many more assessments that could be administered if the billing codes would open in Medicaid.
This is Gary from KDADS, and I can't agree more either. I mean, this is what hinders getting a lot of kids into the services. We have to get those codes opened up for the younger age children so that we can serve them long before they turn 6.
Great, thank you. So with those comments in mind, as we think about ease of implementation, which of these factors ring true? Would this recommendation require a program change? Is it a brand new program? I think I heard program change if we're thinking about changing billing codes.
Carly, can we go back? Should we change that language? Well, I don't know, and the recommendation, just to make it clear to the point earlier, childhood mental health services by including additional language, because I think that's the issue, right? Just there needs to be,
Sure.
I'm never a fan of putting CPT codes in statute, but just to clarify that, yeah, we know some exist, they're just very limited.
Mm-hmm. Great, thank you for that, Candace. I've made that change. Okay. And
Well,
as we're thinking,
from KDADS, and I think besides it, I mean, yeah, there's that program change, but then there's also would need to be program enhancement, because there would be new services that could be provided if we had those diagnosis codes.
great, thank you. What about cost? How would we consider cost? Would this be a barrier to implementation?
Yes.
Okay.
Hey, Deb Stidham, one of the things I was just looking at in terms of ease of implementation, it says pilot program, and I'm just throwing this out. I mean, I was waiting to hear the answer about the cost, and so sometimes if things are expensive, you can offer a pilot. That makes it a little bit more low-hanging fruit for the legislature to continue, because then you have an opportunity to demonstrate outcomes that would work to scale. So
this is Andy Brown with KDADS again, and Deb, I believe that we have piloted this through the Systems of Care grant. So it hasn't been piloted on the Medicaid side, but I do believe we've piloted it with federal grant funds.
do we have outcome data for that?
Maybe.
Can flag that as a follow-up question.
Well, yeah, and maybe we include it as part of the rec too. I mean, I'm saying if we're not already tracking that data.
Great, we can make that change. What about another value that we wanted to infuse into these recommendations was the idea of sustainability. So does this recommendation include strategies for continuity?
This is Andy again, and I believe the recommendations of the task force report include sustainability.
Okay, so now we can either identify some mechanisms that might be required to implement this recommendation. So which of these on the checklist here should we select? And then after that, would be happy to accept if someone wanted to toss out a score between 1 and 10. 10 being very easy to implement, 1 being very challenging. If someone wants to toss out a number, that would be acceptable as well.
This is Andy with KDADS again, and for the check boxes, I think you're going to need federal approval process. Well, not contracts, but agency budget development, and probably systems. I don't know.
Would it require contract amendments?
I'm not certain. So I mean, there'd be 2 contracts that might potentially be impacted by it, right? So there'd be the CMHC contracts, and then there'd also potentially be the MCO contracts. But it could be that we might be able to do it without directly impacting the contracts. I'm not sure.
Yeah. And what about a score? Considering the discussion points we've just hit on, how would you score that for ease of implementation?
10 being most difficult, 1 being least difficult.
So 10 being easiest to implement. So at the end, our highest scored recommendations would be the ones that would be the highest priority. So easier things to implement, and then things with high impacts are good. So,
So this is the one, the harder it is, the lower the score it would be.
Correct, yeah.
I'm thinking a 3 or a 4, maybe 3.
Any discussion there? Does that sound okay?
To me, the state folks really have the best understanding of what it's going to take to do this.
Yeah. Okay, thank you. So now looking at the potential for high impact in this grant, or excuse me, in this recommendation, I don't think we need to go item by item. They're listed on the screen here. Please feel free to toss out thoughts that you have related to any of the questions. So will it benefit a large population? Let's know any special populations impacted, etc.
Well, on the list below, for significant populations, it'll definitely impact foster care and children and low-income individuals, and probably limited English proficient persons. I think it would impact all of the communities, so I don't know that you need to check mark them all. I'm not real sure how that works on the form, but it'd be statewide, so.
And I think the impact would be large.
Great. Any thoughts or discussion about either produce cost savings that it could result in other areas, or how this recommendation could address inequities?
Well, I think the early detection, early intervention has been proven in the past to be a very much a cost saving factor. The earlier we can intervene with an individual, the better off it is. So.
Yeah, and this is Andy.
We could do
with
specific ER emergency room claims. I mean, if we want to get kind of more granular on what cost savings may look like.
Emergency room visits, pediatric visits.
To me, this Deb Stidham, it goes right into the outcomes for adults. I mean, because you're talking criminal justice system involvement, psychiatric stays. I mean, it's more than a dotted line.
Yep.
Yeah, and this is Andy again at Kate Ads, and I would suggest that we maybe put something down there about, like, you know, the initial costs versus delayed savings or deferred savings. Like we will eventually see the results on the adult side, but I mean, we're talking about kids that are less than 5 years old here, so it's going to be a while before they're adults.
Good point. Deb Stidham, I think the other issue too is you just look at family preservation, right? So definitely diverting, you know, entrance into foster care system. I think families are disintegrating sometimes in part because they don't know how to deal with some of these issues in their children.
Well, school readiness and the cost of all the, once a child gets in school, the cost of to the school counseling and that.
And what about
Right.
a score?
Can I have one thing to that, Carly? Maybe it's Candace was saying that maybe what we're really talking about is appropriate versus inappropriate care, or appropriate care settings versus inappropriate care settings. I don't know if we wrote a lot for that last one. I was just trying to think of ways to narrow it down just for sake of ease of content.
Well, I mean, most of these services would be happening either in the home or in an outpatient.
No, that's not really what I mean. What I mean is, you know, if the associated cost that we see in the system through juvenile or criminal or school, that's, you know, that's not really appropriate care on the back end. What it is the early care on the front end.
Thank you. Taking notes as we're talking. So if something seems way offline, let me know. But also at this point, it would be helpful to have, how would we score this for potential for high impact? 10 means high, very high impact. 1 is this would not have much impact.
This is Gary from KDEDS. As the youth director, of course, I'm going to say 10. You know, I mean, 9 or 10, because I truly believe getting these services in is going to be huge.
This is Erin George, and I agree with Gary.
Great. So hearing 2 people agree, I'm going to accept that unless there's a major concern. And I'll move us to our next recommendation. Okay. So next recommendation that you should have on the screen in front of you here is, I believe, from the Governor's Behavioral Health Services Planning Council. It reads, to support, encourage, and provide resources to early childhood programs in implementing and sustaining the Kansas Family Engagement and Partnership Standards for Early Childhood. So first question is this recommendation part of what it would take to modernize the behavioral health system in Kansas?
This is Andy with KDADS again, and I feel like this one also might be more broad than just a standard modernization for mental health. But I do think that there's value in us looking at screenings that might be provided within early childhood programs for mental health.
Carly, this is Rachel Marsh. I was also wondering if anyone is familiar more specifically with what is meant by the Kansas Family Engagement and Partnership Standards, because I'm not clear on whether it's substantially different than what we've already talked about or what it really consists of.
Wes, is that something you're able to speak to? Again, I think this is a recommendation from the Governor's Behavioral Health Services Planning Council.
I think it came from the Children's Subcommittee.
This is Gary from KDEDS, and I'm also a liaison, one of the liaisons to the Children's Subcommittee. So when I first heard this, I was thinking it's connected in some ways to what we were just talking about in the way of those services for children from 0 to 5. And my understanding of it is that, you know, we're talking about the need for more or increased family involvement, parent support.
And this is Wes with the council, and Gary, you're really on target with that, because it really is talking about the family, getting the family engaged and getting some support for the families also. And in fact, we've started doing some of that now, but I think a lot of stuff needs to be tied with that family. I think the first line of defense is that family and supporting that family. One of the things that the subcommittee did do is visit with a number of family members and get a lot of input from them. But I think it does relate to some of these other recommendations that they had made.
And this is Gary, Wes. I think the other part of the conversation is looking at the concept of family broader than just biological family, looking at it as biological family, foster family, the family that is in, you know, that the people that are involved with the child. We have to look at it as something more than just biological family.
That's correct.
And to clarify then, is that broader understanding of family already what's included in this reference standard, or is that something we would need to articulate in a modified recommendation on this topic?
I believe it was intended to be there, being part of the Children's Subcommittee. I mean, a liaison to it. I mean, I know that's a conversation we've had numerous times, so I'm surprised it's not necessarily there. But
okay.
It's good to note it, just because I think people sometimes, when they think family, don't include foster families.
I mean, I do think it's included in the standards itself. So I mean, like this recommendation, like the standards are published by, I think, KSDE. I'm not positive about that, but they're not KDAD's standards. So I'm not as familiar with them maybe as I would be if they were our standards. But I do think that I do think that they look at more than just traditional families in there.
So another question I have as we're looking at this recommendation, then I think I heard something in the discussion. Do we need to modify this recommendation to make it more specific to screening practices?
I think that would be appropriate.
And if so, how?
Yeah, that's.
So this is Rachel Marsh. I think from a child welfare and mental health perspective, it seems like a fairly standalone recommendation that I would presume the encouragement, support, partnership, and resources would have some mechanisms for assessment, monitoring, and keeping an eye on how well the family is functioning. And I'm just guessing, but since this was from the subcommittee, I'm assuming that there was some relationship. And so from the perspective of children in family, I'm wondering if this is, again, just kind of a link to a very strong prevention approach. It's not only opening broader codes, but it's not waiting until a mental health crisis has occurred and a mental health referral is sought. It is engaging with people through different mechanisms early on, and then allowing those screening mechanisms, whatever they are, just simply having eyes on and partnerships with the family seems helpful.
Okay, so I think I heard in that comment that we might be good as is, and that some of that screening is baked into some of that kind of best practice prevention work language that we think they're describing. If that assumption is correct, I'd like to move us on to try to get to an ease of implementation score. Again, please feel free to share your thoughts on any of the questions listed in the ease of implementation column, and I will make note of those here.
Again, not being an expert on this particular program, but the word family engagement does speak to the work that we do every day, and it's not overly complex. It's just a matter of ensuring that you're focused on the family. So I would see it as an easy implementation. It's a matter of probably resourcing it and rolling out some training.
I agree. Plus, I don't think you need rule or statute. It's Candace, rule or statute, pass legislation to do it. It's just more probably a logistics.
Okay, so I'm going to think, I'm hearing grant cycles, cost. I think I heard, Rachel, from you that that is what's keeping it from happening currently, is adequate funding for this.
I can't speak to why it's not happening, except for that's always the reason, right? So
yeah.
The operator.
The adequate focus on family engagement through all of the necessary pieces, funding, training, development, rolling it out. But it is not hard conceptually to engage family.
And is there a score someone would like to throw out for ease of implementation? I heard this one seems easy, but I'm not sure what number you'd like me to put by that.
I'd put a 1 or 2 because I do think it's an easy thing to implement and to get done. And I think we have already started doing some of those things.
Okay, I think I translate that to a 9. A 9, right. A high score being.
I mean a 9. I'm sorry.
Okay, cool, great. Any other discussion on ease of implementation? If not, I would direct your attention to potential for high impact. What do we think opportunity for impact looks like here? Welcoming any comments on the questions listed here.
This is Gary from KDEDS. I think the impact would be fairly high.
Great.
And when we're looking at families, I think we're going to check most of the boxes below that too, unless folks differently. Kind of the same as the last one.
I'm going to make the same note on communities. And what about a score for high impact?
I'm going to say we're being 9 or a 10 there too.
Okay.
I would go along with that. I think a 9.
Sounds good. Then I will move us on to our next recommendation to discuss here. And this is, again, another one from the Governor's Behavioral Health Services Planning Council, I believe. Give you a moment to read that. But again, the kind of first question is this recommendation part of what it would take to have a modernized behavioral health system?
Deb Stidham here. I think it does.
And this is Renee at Advent Health, and I would agree with Deb.
Great. And what are our thoughts on ease of implementation here? What considerations should we mark in the column on the left-hand side?
So for the most part, I mean, if we're looking at this as a state perspective, this would pretty much be new programming. Cost would be a barrier. The recommendation does not include any sort of continuity recommendations, right? Like it's just
Like it would
ongoing.
all be, yeah, seems like it would all be pretty tied to if funding was available for it.
Yep. And then for mechanisms that we may have to affect, I think you're looking at legislative action to change BSRB requirements, probably. And for we did pass some legislation already around gatekeepers in the schools, but there may be other community gatekeepers that they're thinking about that might require legislation. We wouldn't need federal approval. I don't think we would need a regulatory. Well, we might probably need regulatory process at BSRB. We would need contracts for the training and the workshops and the materials. We need budget development because we don't have a budget for this yet.
So I'm just going to bring a different perspective. This is Rachel Marsh with the Children's Alliance on the ease of implementation. Now, I've never done a statewide marketing or communications campaign, so I can't speak to that specifically. But when we think of the opportunity that we've learned through the COVID-19 for virtual trainings and how at least our organization was able to lift up existing trainings and get them out statewide with a fairly quick turnaround and for a fairly low cost. I think depending on how you approach this, it could actually be quite simple. And unless we want to do a major advertising campaign that would cost thousands and thousands of dollars. So I think the ease of implementation is how complicated we would want to make it. And I also don't know that it necessarily has to be legislative when you consider that the BSRB could simply offer this if we're increasing available support and encouraging it. I don't think the legislature would have to.
Yeah, I guess I was in Rachel, this is Andy again. And I guess I was interpreting it as making it a requirement for the BSRB licensures.
Right.
I agree. Really, this is a multi-part recommendation, which part of me not a fan of those in these kinds of situations, just because it's we're lumping together things that are very different. So the very first part of this really, I read it as public awareness, and that does take some concerted efforts and sustainability to keep that up. Because you're really trying to reach the public. The second part of that is much more focused to enhance the competency of licensees around this issue, which is never a bad thing. I think if we've learned very much in the last 10, 15 years about this issue, though, is that training up lay people also to address this is probably a bigger, if we can get them to the clinician, right, we're probably miles ahead. It's how to get from I'm acting a certain way, I'm saying some certain things to somebody's noticing to therapy, right? So this is a comprehensive recommendation written in a few sentences.
Yeah.
And it definitely, I think, is going to have to take some fun. I mean, it'll take all of these things to do all of it.
Yeah, and I don't want people to feel like we're not doing any of this. I mean, we are. It's just happening in pockets, and it's not statewide, generally speaking. And so, but I do feel like, for example, we've been looking at psych armor training for CMHCs and for VSOs, and that training costs money. Like if we want to be able to monitor who's had it and what the level of impact it's having, it's gonna cost money.
With that discussion in mind, oh, go ahead.
Oh, I just wanted to say, this is Lisa. The other thing is to look at, what training programs we choose, because like the association did assist suicide training, and I think some people have had success with it, but it's a 2-day training, like a community training. So getting people to sign up for that class when it's 2 days is very hard to do. So if we're going to pick some trainings for the community, it needs to be in smaller time frames so we'll get people that actually want to attend.
Thank you for those comments.
This is Gary. I agree with Deb and Andy. Well, everything that's been said really, in the sense that this is a multifaceted kind of issue. I mean, we've got the stuff about distributing and promoting op-eds. We've got the idea of changing some of the stuff with the BSRB. We also have the idea that we need to have, it seems like we need to have some coordinated effort coming from the state of someone to promote all of those different things. So a position in, as such to manage that does seem to be part of what the new program change. I mean, for me, a program change would be that we're talking about making it a priority and getting staff involved to make those things happen. It's not just one piece.
Mm-hmm.
This is Kelsey with KDHE. I just wanted to add that KDHE, our Bureau of Health Promotions, did receive the CMSA Zero suicide grant. And there's a component within that of increasing availability of those evidence-based trainings. And I believe part of the plan there is to partner with our community mental health centers to bring those trainings to the different communities across the state.
Great, thank you for sharing that, Kelsey. With this discussion in mind, how would we score the ease of implementation on this? Recognizing that it's multifaceted, so I think accepting it as written, what would it take score-wise, 1 to 10, to implement this multifaceted recommendation?
I think probably an 8.
8 would be easy.
I'm going to translate that to a 3 because I think I see.
I keep doing that backwards.
I don't think I've found a good way to pitch the scoring rubric yet. So we'll see. That's on me. I'll leave it at a 3 unless someone has other input on how that one should be scored for ease of implementation.
Well, I would agree with a 3 also, but I want to just comment a little bit on what Andy says. When those recommendations came up from the different subcommittees, that didn't mean we were not doing things. We were doing things in this area and everything. And actually what we're talking about is enhancing what we have started. And that's how some of these recommendations follow from the subcommittees. Because we've got the prevention subcommittee and we've got suicide prevention. We've got those things, and we can build on that.
Yeah. And I will say, this is Andy from KDADS again, but I would say that I do feel like we have a fairly comprehensive state suicide prevention plan that has just been redone, that I feel like has a lot of good content in it. And I also feel like if I was going to sit down and write some recommendations about what we need to build suicide prevention infrastructure here in our state, we could come up with some much more narrower recommendations that I think would maybe be more beneficial than this one in the long run.
Andy, I might put a pin in that comment because I think in kind of our second half of our call, I think we'll have some of that conversation about new recommendations.
Yep.
Do we want to score this one for high impact, or do we want to address suicide prevention recommendations kind of from scratch?
I mean, I would neutrally give it like a 5 for impact as written.
Okay. In the interest of time and wanting us to get to a few others here, I might move us along then and leave that one there, recognizing that there's probably more work to be done. So now we're looking at a recommendation that the kind of tag or handle here is PS recommendations. It's an evidence-based practice work group for behavioral health promotion, the formation of that group. And then there's a number of topic areas there that the thought is that kind of group could address. Is a group like this important for the modernization of the behavioral health system?
Can I ask a clarifying question, Deb Stidham? And
Sure.
I don't know if Wes knows the answer to this or who, but I guess I just don't know what a work group is. I mean, obviously I know what a work group is, but I don't understand it in this context.
Well, yeah, go ahead, Gary.
So Deb, there are 2 work groups that are sort of defined in language from SAMHSA. One of those is the state epidemiological outcomes work group, and the other one is the evidence-based practices work group. So the SEOW and the EBW are both work groups that SAMHSA recommends that states have in their behavioral health planning groups.
Okay, yeah, I've definitely heard of the epidemiology work group.
Yeah.
I guess when it comes to the actual product of a group like this in the system to modernize the mental health system, I mean, this is a great start. I guess most of these have been a little bit more concrete action steps. Does that make sense? I mean, this would just be, I don't really understand how a work group is going to create more evidence-based practices occurring in the state.
Yeah.
Deb, let me answer it this way.
Okay.
With the council, we do have a new subcommittee, which is Evidence-Based Practices Subcommittee. And what they're doing is looking at all the evidence-based practices in the state of Kansas and where there's barriers or where we don't have those, or how we could get evidence-based practices, the toolkits and things like that. So what we're doing right now is evaluating the evidence-based practices in the state of Kansas and working with KDADs in that area also. And that's basically just a subcommittee looking at that, and they're looking at it from many, many different angles.
Yeah. And Deb, I would agree. I don't necessarily feel like this is a very, I don't know that the legislature was the target of this recommendation to begin with. So I think it could be removed.
This is Gary from KDADS. I'd agree.
Okay. Heard agreement there. So unless there's concern, I'm going to move us on to the next one. I'm not going to score that. Okay. Next is about publicizing. Next recommendation is about publicizing the availability of prevention tools. Looks like on the kansaspreventioncollaborative.org website. Is this an important recommendation for the modernization of the behavioral health system?
Deb Stidham, I guess I just have a question for KDADs in terms of what's the barrier to doing this now?
Yeah, I mean, again, I don't know that there's a barrier other than funding, right? I do think that there's activities around trying to promote it. And again, I'm not real sure that this was intended to be a legislative recommendation.
Okay, am I hearing that as a recommendation to strike this one for this group then?
Yes, I think so.
Okay. Next recommendation has to do with housing and homelessness. Says to create a housing specialist certification and ongoing education training curriculum. Again, is this recommendation an important part of modernizing our behavioral health system?
So I can certainly see the value in us having both certification and ongoing education or continuing education for housing specialists. I think that would be probably somewhere in the neighborhood of like a program overhaul. And as far as cost being a barrier to implementation, yes. I mean, I have a feeling that pretty much everything we're going to talk about is going to be a cost barrier. But, and then I do think that it includes continuity based on the fact that it's ongoing education curriculum. And I would say that we would probably need agency budget development and systems IT.
Is there a score that comes to mind for ease of implementation on it?
Can I just ask a question, Deb Stidham? And I should know the answer to this already. Can someone explain in a couple sentences how this relates exactly to modernizing the mental health system?
So this is Andy with KDADS, and we're specifically looking at housing as a social determinant of health. And we're looking at how we can integrate housing supports into Medicaid and also into our work with the CMHCs and our SUD providers.
Housing is truly a foundation for building mental health and stability.
I'm not disagreeing with that. I don't know. It's just it's a unique recommendation for this list, especially for prevention and education, but okay.
Yeah, it might fit better in a different category, right?
I think it would.
Okay, I'll make a note to move to another category, and we'll let that group address there with the notes we already have. Okay, in the interest of time then, next we're looking at a recommendation from the Governor's Substance Use Disorder Task Force from 2018 around provider training. Looking at providing training on opioid prescribing, MAT, pain management generally, and risk identification. Is this an important recommendation as it would contribute to modernization of the behavioral health system?
I mean, so I would consider this similar to our previous one, which is that it may fit better in a different category. I'm not sure that I'm tracking all of the training stuff being part of an education topic.
Okay, can you say more about that? Where would it be making more sense to you outside of, so training, I think got sorted here.
Like I think it would fit better in workforce when we're talking about training professionals.
Got it. I'm sorry, Deb, were you gonna?
Yeah, I was just curious. We've been doing this for, gosh, years now. And I guess I'm just wondering you can always do more. It just feels like the people that have gotten on board are going to get on board. And it feels like we're more on sustainability around this more than, you know, launch an initiative and make a big splash about it. It feels like it's time to move on to some other things like, you know, amphetamine treatment and co-occurring disorders and things like that.
Yeah, and this is Andy at KDADS again, and I would say, Deb, a lot of these recommendations come from reports and things that are, you know, between 5 and 3 years old. You know, like we don't have a lot of recent recommendations.
I was actually going to suggest we strike it altogether.
Any discussion on that?
I'm not saying it's not important. I just don't think it. I think we should be mindful of our priorities.
Yeah, this is Wes, and I certainly would agree with that.
Okay, hearing 2, I'll call that a decision there. Next recommendation then again from the Governor's SUD task force is around K-TRACS education. Recommendation is to develop and disseminate materials on K-TRACS and CDC guidelines to healthcare providers and students. How does this recommendation contribute to modernization?
So there's already a lot of this that's in the Medicaid 115 waiver for the SUD IMD exclusion.
Mm-hmm.
I don't know that it's necessary for us to focus on it.
Okay, we'll strike that one. And next one, Andy, I wonder if this falls in the same category. It's around provider MAT training, increased capacity and access to MAT, medication assisted treatment in Kansas through provider training.
Yeah, I do recognize that this is a need, but I think it might fit better in workforce.
Okay, so this one, rather than striking, the recommendation is to move to the workforce group.
That would be my thoughts. I can hear Deb or anybody else's thoughts too.
Yeah, I'm fine with that. I mean, increasing the use of medication assisted treatment is a little bit like the other topics that we've talked about today. It's multifaceted. You can train people all you want, but until we have funding for the indigent for these medications, there's not going to be a high demand to do much more than when I think what's already happened.
Great, thank you. From there, I might actually go ahead in the interest of time and move us to our discussion of previously identified barriers. So excuse the fast scroll here. I'm going to get us to our list of barriers that this group had previously brainstormed related to this topic. So this is, we don't have any existing recommendations. These are barriers this group identified, and we need to come up with something that would be a recommendation for this group to consider related to each. So those are listed on the screen here. My thought is someone toss out where we would like to start, and I can take notes on the screen and we can go from there. So the barriers we have listed are inadequate funding as it relates to funding of K-TRACS, funding of suicide prevention efforts, education on behavioral health system navigation, and then education for parents, maybe similarly to behavioral health system navigation when parents don't know where to kind of access the system in a crisis. That was referred from the finance and sustainability group. As far as new recommendations, where would we want to start that conversation?
Well, this is Andy with KDADS, and I think the education for parents and crisis is a very valid topic for us to talk about in terms of modernization.
Okay. What opportunities exist to make a recommendation around that work?
So currently we are trying to fund through DCF and have been for a couple of years trying to fund mobile response and supportive services. Or sorry, not supportive services, mobile response and stabilization services. And specifically for youth. That's been very effective in Oklahoma. And I think it could be very effective here if we were able to implement it. DCF is currently attempting to fund that with the Family First Prevention Services Act funds. And you could say Oklahoma and other states. I was just calling out that Oklahoma's done a good job with this. But I feel like we still need additional funding for the program and for sustainability of the program. There is also the 988 number, which will come into effect July of 2022, if not before. And when that number is available, that would give parents an easy number to remember, an easy number for the state to promote. But we need funding in order to make sure that that number is answered. Right. So right now, 988 is going to redirect people to the National Suicide Prevention Lifeline. Currently, our in-state answer rate for that lifeline is only at about 60% on a good day. So if we tried to set up a crisis response connected to that phone number, without additional funding, that we wouldn't have the ability to dispatch those crisis services effectively.
This is Kelly from DCF, and I agree with Andy. In addition to expanding our service array of crisis services, so again, that's funding, but I think the mobile response RFP that DCF has out now is just a very bare bones beginning of a good crisis stabilization service model. And there is a lot of additional services such as like crisis stabilization beds and other innovative techniques that we need to add to be modernized that will help us, that will end up being a financial savings in the long run because it will decrease number of kids that go to foster care involved in juvenile justice, in addition to financial spending on acute stays and ER visits and law enforcement contacts.
PRTS.
Mm-hmm.
On that last one, the crisis stabilization beds, I'd propose that we save that one. The next meeting of this group, the next topic you'll be addressing is on treatment and recovery. So I'd propose that we talk about it in the context of those recommendations. Would that work for you, Kelly?
Absolutely.
Well, and looking at this too, 988, the federal government does allow for states to to tax the cell phone bills for additional funding. So that may be something that it does take the state to act on that.
Would that be a recommendation the group would be interested to make, Gary?
I would think so. I mean, I'd like to hear from others, but I certainly think that's a way that we can get funding for that 988 and for other crisis services.
Yes.
And maybe say it for me one more time. Oh, sorry, going back to Gary's comment, the recommendation, it would require state action to have this added to cell phone bills, did you say?
Yep.
Yes.
Okay. Sorry, go ahead, Shanna.
Yeah, Shanna Burgess with Johnson County Mental Health Center. I've, in reference to the 988 and the National Suicide I've always been interested in tying that back to the established system of community mental health centers that already have crisis lines and trained mental health professionals on staff, and what a benefit for someone calling in to already be connected to their community mental health center. So I would just add that to the mix of thoughtfulness in establishing that system in a little different way.
Yeah. So Shanna, this is Andy Brown with KDADS, and I would say that there's nothing stopping Johnson County from doing that now, right? If you want to be an NSPL hotline, you can be an NSPL hotline and you can help answer calls from Johnson County. That'd be terrific.
Yeah, I would love to see, I think collaboration across the state to have each of the locals, so that just something to be thoughtful of. And
ComCare is already doing it down in Wichita.
Yeah.
So if you want to do it, you can.
Thanks.
The CMHCs could play a major role in the whole mobile response system as we get that rolling out.
Great. So on that topic, and I recognize we certainly don't have recommendation language, but certainly intent hopefully is what we're wanting to capture here. So around mobile response and stabilization services for youth, have reference to other states where there have been successful models of that, but we need additional funding for that program and a funding mechanism in place that would sustain that program, as it's currently kind of the first pieces of that is being rolled out now with Family First funding. Does that sound correct, or are there any additions or corrections? Okay, and then the other note I have is that we want to make a recommendation on funding almost like wraparound support for the 988 number that will go live in July 2022 to ensure that answer rates certainly don't drop, but also can hopefully increase. And the specific recommendation that I heard there was recommending that the state make that change to cell phone billing to fund that program. Any additions or corrections to that piece of it? Okay. Looking at the other items on the barriers that this group had come up with, others that we would like to have some initial conversation about what some recommendations there could be. So that's education on behavioral health system navigation. Any conversation the group wants to have around K-TRACS funding.
Well, I think I'm the one that may have made the comment about the K-TRACS. It was just an example of something that you put into place, and then years later, you're trying to figure out how to pay for it when it's clearly extremely important and part of the opioid abuse response system for most states. So I don't know. I don't even know where that landed, honestly. I never heard how they decided to fund K-TRACS. It's still up and running, so somebody figured out something. I don't know how sustainable it is, but I think in general, as I sit and look at over my time in the field, my time in the state office, I think there's just a lack of understanding about the value of prevention efforts. I think we're so used to always dealing with people in acute crisis or, react. I mean, government tends to be reactionary. That's about all they're resourced to do. And I think at some point, we have to create a way that prevention knowledge, prevention specialty. We used to have certified prevention professionals in the state. We've lost that. I just think everything from the why we focus on prevention to the actual skills and knowledge that it takes to be a professional in that arena. And then, what we can expect in terms of outcomes and cost deferment for state systems. There's just not much time, energy, and value in that, to be honest. And somehow I think we need to remember that as we're looking to roll out prevention things, because I think those are the first things that get cut.
This is Shanna Burgess, and I would just say that having some statewide support for that certified prevention professional certification would be a really great add-on. You know, I know it was mentioned earlier for the housing specialist certification, and I think that, you know, if this group's charge is in relationship to prevention and education, if we could build up our cadre of prevention professionals within the state again, that would be a really nice impact for the prevention work across the state.
Can anyone speak to what are the barriers in place that we could address related to the state prevention specialist, that credential? What barriers exist?
Well, so this is Andy with KDADS, and right now there's really, I think, maybe 3 barriers related to the prevention credentials. One is that the current credentials are managed by they have to be managed by a board, and that board and the number of people that are credentialed within the state has dwindled to the point that I don't think right now they have the capacity really to build on it. So we would have to invest in the infrastructure of the credentialing process, right? And reconnect with the international or national group that oversees those credentials. Second one is just requiring the certification, right? So because employers aren't requiring the certification, there's no need for individuals to pay the, you know, fairly substantial costs for the certification. So since we haven't had an employer requirement from the state for the credential, that's what's led to the decrease in the number of people maintaining their credentials or seeking them. And then I think the third one would be that if we want to fund people getting those credentials, then we're going to need to identify how we want to do that. The funding barrier, I don't think is insurmountable. It would just require sort of right now we currently fund prevention at the lowest level possible under the federal requirements. And so we would have to change how those funds are allocated within the prevention system.
This is Deb Stidham, or get the state to invest in prevention. I mean, that's,
yeah.
I mean, it's always been a small pizza for a large army, no matter what you do with those prevention funds. It's just never been sufficient. And I just think we need to be clear about that. I mean, I don't know, we're getting a platform that we haven't had in a long time to really make that case. And it's one of the topics we were asked to address. And I mean, I wouldn't even give Kansas a passing grade personally.
Right.
And Deb, if we were to make that recommendation, how do I refer to the specific fund that we're reaching the national minimum?
It's the Substance Abuse Prevention and Treatment Block Grant. It's the prevention set aside that's required by the federal government.
Yeah, there's no state dollars.
Right. We do only what we have to get the block grant funds.
So those are federal. Okay. So the recommendation that I'm hearing then is that we encourage that there be just some state funds put towards prevention.
Yeah, I mean, I think at some point we're gonna have to put dollars with a recommendation so people have a price tag, but.
As we were talking earlier about prevention within mental health, I mean, prevention needs to be something that's expanded in a lot of ways across the board, whether it's mental health, substance abuse, and looking at it as a connection, that it's not really that separate. The federal dollars are definitely distinct in what those are to be spent on.
Mhm.
I think we could, as a state, look at prevention overall.
Yeah, I mean, you could put it in that very first bullet point. You could say, sorry, this is Andy from KDADS again, but you could put another bullet point under inadequate funding and just put fund, substance abuse prevention.
Hey, I'd like to ask Debbie Wilsey, who I asked to be part of this committee, a question just about, courses in higher ed and whether you see much prevention talked about in that, like in social work or other behavioral health groups, discipline.
I mean, right off the top, pardon me, right off the top of my head, I can't really think of anything. I was following along with you and remembering all the prevention efforts we did have and what we used to do. And I remember who was in those positions and what that involved. And I was thinking, you don't notice things when they're gone sometimes. You notice a new extra thing, but it's like, oh my gosh, that really is gone. I think probably because it isn't really existing, then the education sort of follows. I mean, you prepare people to do what is needed currently out there, and without prevention being there. I mean, I remember the prevention center here in Wichita, and I can't honestly tell you that I think we're including much of that. It is more reactive because that's what's required when you're out there. So that's a fascinating idea, and probably if there was more of a presence in agencies in the community, probably the education would follow. But I could probably deeply go dig and find like one thing, but I don't think we're doing much of that.
Thanks.
Great. Well, thank you all for the helpful discussion today. So our goal is certainly to kind of go deep on each of these topics, in the course of one meeting. Each of them will be probably as equally broad and complex as prevention and education was. We just have a lot of ground that we've been asked to cover here. We have about 3 minutes left in our meeting today. So I wanted to quickly describe for the group what some of our next steps will be as we move towards kind of getting a roster of recommendations to put forward to the special committee in early December. So you'll notice there were some of the recommendations in the crosswalk that we did not have the chance to get to in discussion. Expect a Qualtrics survey from me that you will be able to click through and just hopefully just for the most part click like multiple choice questions and provide snapshot reactions to each of those recommendations. And then at the beginning of our next working group, we'll present the results of that Qualtrics survey, and hopefully we'll be able to move through those pretty quickly and have something like consensus that you would have each submitted only to me through that Qualtrics survey. But we'll certainly have the chance to discuss further at the start of our next meeting. The other thing that comes to mind as we're thinking about surveys, you should have a doodle scheduling poll from me that will get our next 2 meeting dates. If you can complete that, really today would be great. I'm planning to schedule the next round of working group meetings by the end of the day on Thursday. So certainly completing that scheduling poll by Thursday would allow me to select times that would work for as many of you as possible. So that is the next item. And so then once you've completed that scheduling poll, our next topic will kind of go in order in that WG2 crosswalk agency document. So the next topic that we'll have is treatment and recovery. So look for that meeting appointment from me. The next item that we'll address is treatment and recovery. Similar to this, we'll be running through the existing recommendations and then spending some time building out new recommendations. Again, when I send out those materials, if there are any in advance that people can say, hey, this is, no longer relevant or has already been addressed, please feel free to strike those from the list, send it directly to me. We'll strike those from the list, and then we'll have, fewer that we need to get through in the meeting. And then lastly, in regard to treatment and recovery, I have some additional experts, supplemental experts that you all brainstormed in your last meeting that I will invite. But if there are others that I should include as it relates to that topic, let me know. Just send me an email with their name and contact information, and I will include them on the meeting invite. That takes us to 4:30. So I want to see if there's any questions that I can answer from any of the working group members or others on the call here about our next steps.
Carly Deb Stidham. I reviewed the minutes that you sent out from the last meeting. I'm not sure all the members got included as attending.
Okay.
My name was not on there. I didn't see Gary Hanault's name, so I don't know who else.
Okay.
And then the additional expert, in addition to someone from a college or university, was an SUD prevention professional, not a treatment.
Got it. I will make a note that we go back and look at that to make sure we have certainly the attendees correct and those other items as well. Okay. Any other questions I can answer for the group on next steps? All right, well, that adjourns our meeting. Thank you all for attending, and we will talk soon.
Thank you.
Thank you.